It is my pleasure, and again, I'm not going to do long introductions. I would like to make a comment on each speaker that I'm going to introduce. So Dr. Wahbeh, I've known for, 15, 18 years, and despite his stature, he is older than 15 years old. Ghassan has been a wonderful friend. I did not say that. He has been a valuable resource at Children's Hospital. He's the director of the IBD program there. And Ghassan and I have literally known each other for more than 15 years. We've been collaborating on things like this for the last 15 years. He's just been a wonderful resource. If you guys don't know who he is, he's the director at Children's Hospital, and he's really been kind of our go-to guy. No offense, Dale, you're younger than him, you got here later. Dale, his colleague, who's also speaking. But I want you guys to welcome Dr. Wahbeh, who's going to give us the first talk on diagnostic testing in IBD and risk stratification. Thank you very much.
Thank you very, very much for this very kind introduction. All right, my topic today is diagnostic testing in IBD and risk stratification. Forgot that I'm doing luckily here. About ready to move with the slide. There we go. These are my disclosures. So we'll go over what we have today in IBD diagnostics. I'll touch on what we have to use as predictive tools for the course of IBD, and then talk about some future directions that are really badly needed in our field today. When do we need testing? We know that we need testing when patients present with symptoms. We want to diagnose them with IBD. We also want to differentiate the extent, the type of IBD, and after that, maybe try to get some sense of where this patient's IBD is going. So can we predict where this disease is going and how the response to therapy will be? And once we have that, I think the question is, how do we monitor disease? Now, disease monitoring will be covered by some of the wonderful talks that are lined up for later today. And I'll focus on these three first points: diagnosis, differentiation, and prognosis. Let's start with the diagnosis. First and foremost, we need to rule out inflammation versus non-inflammation. And fortunately, we've had a very expanding list of inflammatory markers that we can use, from the usual CRP and sedimentation rates that we can use, and also the stool markers that have really gained popularity and reliability when you look at differentiating patients with non-inflammation versus inflammation. But they're not specific for IBD, so they just tell us that patients have inflammation. And then we move on to the gold standard that remains today, which is endoscopy. And we need endoscopy, we need tissue diagnosis of IBD with some exceptions. And that's where video capsule imaging or enteroscopy, balloon enteroscopy, and imaging, cross-sectional imaging with CT and MR comes in handy. But as far as we stand today, the use of genetics for making the diagnosis and the use of serologies for making the diagnosis, not prognosis, but for making the diagnosis, is not really part of the standard workup. So no to genetics and not yet for serologies for making the diagnosis. Now, a bit about the genetics of IBD. Now, ever since we started looking at genetics, it really blew up after the NOD2 gene was identified as a risk factor for IBD. However, it blew up so much so that we have so many genetic markers for the disease that make the use of the genetic testing not quite reliable and helpful. And so if you look at the twin incidence of IBD, in Crohn's disease, it's barely above 35%, and in ulcerative colitis, 5 to 15%. So really limited role for the genetic testing in that realm. We do have a very unique subset of children with IBD who are under the age of 1 and maybe to a lesser extent 2, where you can identify one gene causing the IBD phenotype, and this can be cured with a stem cell transplant. So this is really the exceptional patient who's incredibly young with a severe phenotype of IBD. Now, what looks like IBD is what we need to rule out, and these are the conditions that we commonly talk about. If a patient has bloody diarrhea for over 3 weeks, especially over 6 weeks, you can rest assured that it's unlikely to be an infection unless there's an underlying significant immune deficiency, such as HIV or congenital immune deficiency. And then we have to think about other differentials, NSAIDs, drugs, for example, transplant patients on mycophenolate or MMF. And then less likely instances beyond IBS, less likely conditions such as radiation enterocolitis or solitary rectal ulcer syndrome, ischemia, or malignancy, especially in your adult population. And once we rule out these other etiologies, we go for our gold standard. We have a tissue diagnosis of IBD or diagnosis based on imaging and the clinical picture. Then the classic teaching was to try to identify what is IBD and what type of IBD does our patient have. And is it Crohn's, is it ulcerative colitis? So I listed the classic teaching of what is the difference. Interesting to talk about with your med students and your residents and trainees, but boring to death. The reason is we know that it's a blurry picture. We're not at the age where we have to say you have this or you have that. We have a huge overlap in how we treat our patients. Surgical treatments may differ a little bit. However, the more important part is to tell the patient you have disease in these areas, we're gonna follow it up, and we will do our best to heal it. And so the classic high yield features for Crohn's disease, the granulomas, well, there's a big chapter about granulomas. Not all granulomas are Crohn's granulomas. You know, you have to talk to your pathologist about how mature was this granuloma. Was it poorly formed? Was it just a cluster of multinucleated giant cells? Or was it a really well-formed cluster of cells around some what looks like a foreign body that is stuck there? Fistulas and abscesses. You could see a perianal limited fissure or fistula with ulcerative colitis, not an extensive web of fistulizing disease. So again, the message here is that a lot of these features could be blurry with some exceptions. What I wanted to focus on in this slide is what are the atypical features that you could see in ulcerative colitis. One example is when you look into the terminal ileum and you do not see disease, but the biopsies come back to state that there's microscopic ileitis or acute ileitis or focal acute ileitis without mature granulomas. And that's still not necessarily a Crohn's feature versus ulcerative colitis versus some backwash ileitis. The finding of duodenitis or gastritis, even if it's focal, that's not a feature of Crohn's disease. And then an interesting feature of what you see here, which is the cecum, and you see some inflammation immediately around the appendix, but normal tissue all the way until you get to the left colon. And that's what we call the cecal patch. Again, not a unique feature of Crohn's disease, but it could be certainly consistent with ulcerative colitis. And then the phenomenon of relative rectal sparing. You see the rectum not looking very inflamed, but the rest of the colon entirely looks inflamed beyond the rectum. But on biopsy, there is microscopic disease. So this relative rectal sparing is not necessarily consistent with Crohn's disease. So we should be careful in how we label our patients. And part of the reason is, you know, patients want a diagnosis they can Google. And if we trap a patient into one category, I think we trap him into a set of Google search results. And I'm sure that we all know that that doesn't usually bring a lovely conversation to your office. So once we have that description of what patients have, we look at any extraintestinal manifestations. And that's not necessarily the focus of my talk today, but looking at liver tests and joint inflammation, skin issues, eye inflammation, bone involvement, whether it's bone inflammation or chromo, recurrent multifocal osteomyelitis, and then bone disease, that is what Kendra will cover in her talk, osteoporosis and osteopenia. And also ask the big question of, do I know how this patient's course will be? Can I predict how this course will be? Now we know that IBD is continuous destruction of the intestine if we let it go untreated or undertreated. And even without having symptoms, you see this course of progressive damage in the bowel with possible flares. But even between the flares, most patients will not go into remission, into deep remission. The inflammation will always be active. And so our goal is really to try to tell which patient will go into this and which are probably the exceptional patients who really stay with inflammatory disease for a long, long time. So most patients start with inflammatory phenotype, ulceration without strictures, without fistulas, and then with time, they progress to having complicated disease. Now, it doesn't mean that inflammatory disease is easy disease, by the way, but we have traditionally looked at bad outcomes as surgery or fistulas and strictures. But a minority of patients will have mild disease. And perhaps these are the patients that we do not need to treat with our effective combination type therapies up front. And that is actually one of our biggest questions today. But when we look at seeing your patient, what can you tell about this patient that tells you this is going to be a bad course, we need to use our most effective therapies up front and without delay? Well, this is easy. What we're looking here at is deep ulcerations, maybe a stricture here, in the intestine on your baseline diagnosis. We all know this is bad. Other clinical factors that we can look at, age. Age does matter with the risk of bad prognosis. Extensive small bowel involvement or colonic involvement with deep ulceration, perianal disease, fistulas. Now, we don't see histology up there. So up until this point in time, we don't think that histology is as predictive of a bad course as seeing big, deep ulcers. So keep that in mind. What about low risk? When you look at this patient, commonly you probably see this with patients who get screening colonoscopies, and in the TI you see a few aphthous ulcers. So very superficial, very limited. That's not the same patient as the first set of pictures that I showed you. And again, if you're younger, you have limited disease, you don't have perianal disease, and you haven't had prior surgery, and you don't present with a fistula, sounds like this is an easier course. It is a little deceptive though. And I want to point out that despite looking at CRPs, despite looking at fecal calprotectins, it may not be enough to predict how this patient is going to do later. A very high CRP or a very low CRP does not mean you're going to have an easier course. Now, labs can be helpful to predict relapse of your inflammation. But again, doesn't mean complications, doesn't mean surgery. The genetics as predictors, probably not that helpful yet. Now, if you combine maybe serology with genetics, that could be a helpful predictive tool. So serology does have some data that I will go on in the next slide. What is promising are niche genetics. So in one unique study, we were able to see that if patients have a unique genetic marker for an abnormal laying of the extracellular matrix, this patient is already into the stage of fibrosis at diagnosis, and probably nothing we do will take that risk of developing that tight stricture away. So there may be unique features of the patient's genetics and serologies that we are seeing progress in, where you can predict that this patient will have a tight stricture, maybe move to surgery earlier on. The fecal microbiome, very early stages, hard to use those data for any meaningful predictive role. And now serology, I remember Dr. Lee had a wonderful conference about 15 years ago, and I stood at this podium and talked about our data in this study in collaboration with Marla Dubinsky's group. And we showed that the more antibodies, the serologies against antimicrobials, ASCA, ANCA, the more you have, the more likely you will have complicated disease. But again, I will point this out that if you look at patients who did not have any markers, they still had a complication of surgery or fistulizing disease. So the accuracy of the testing is quite not there yet. Now, it doesn't mean that serologies are not helpful. I think in combination with other models, it may be helpful. And this is where new tools such as this tool, the Prospect tool, can actually offer us the future of predicting disease course. If you look at a lot of patients where you study their genetics, their serologies, their phenotype at diagnosis, and you put that together, you could come up with an equation to say you have an X% chance of developing complications. Now, the data go as far as 3 years, so that's not enough. We want to know what happens in 5, in 10, in 15 years. And so if you take those patients over 3 years, 80% of our patients with Crohn's disease will have a complicated course. 80%. So that's your prediction already. So how do you tease out which of the rest of the patients, the 20%, will have an easy course? Now, another way to frame it, and the key thing here is detail. If you have the markers for high risk, you have a 26% chance of having a very complicated disease. If you have markers, if you don't have markers for bad disease, you have a 14% chance of having complications. So again, it is a little bit blurry that there is no ultimate safety in a lot of testing that we do today to predict disease. So where does that leave us? I think what we miss sometimes is focusing on predicting the disease behavior right at diagnosis. But as we stand today, I think we have a window after diagnosis and after we start our therapies where we can predict how the course of those patients will be by looking at endoscopic remission. This is probably one of our strongest predictive tools today. In this meta-analysis, when you look at endoscopic remission after the first colonoscopy after you start treatment, you can clearly see that if you go into mucosal healing, you have long-term remission likelihood, and you have a good chance of maintaining mucosal healing later, and a lower risk of surgery. And so how can you predict better healing? The study showed us that if you actually follow beyond symptoms, calprotectin, serum inflammatory markers, you have a much higher chance of having your patient heal their ulcers. So we can predict how patients go into mucosal healing, and we can predict for patients who go into mucosal healing that they will have a better course of disease. So where's the future? We need to recognize what is mild disease, because most patients will have beyond mild disease. And we need to look more at the serologies and the genetics of the niche types of IBD. And these will probably help us predict which patients will need earlier surgery or earlier specific types of therapy. And maybe we can minimize toxicity from some of our therapies. And last is probably identifying patients before they even show up to our office. We know that things like serologies can show up before diagnosis. And so that might be one way of the future to say you're at risk of developing IBD in 5 or 10 years. Let's do something different now. And I see that as the future of where we go. Thank you.